Hello, everyone, and welcome. Today, we are taking a really close look at an organism that has, let's be honest, earned its place in the modern hospital rogues gallery, Corynebacterium jekeium. We're going to break down everything you, as a microbiologist, need to know about this often underestimated but critically important nosocomial pathogen.
And, this quote really gets to the heart of the story. We're going to trace the evolution of our thinking about Corynebacterium jekeium, how it went from a bug we might have brushed off as a contaminant to a multi-drug resistant threat that absolutely demands our full attention, especially when it pops up in a sterile site culture from a high-risk patient. Okay, so just so you know where all this information is coming from, this entire explainer is built on a comprehensive Gemini deep search, which pulled together all the latest research and guidelines. If you want to see all the primary sources and citations for yourself, you can find the full notebook document linked right alongside this explainer.
So here's our game plan. We'll kick things off by looking at its journey from normal skin flora to a serious pathogen. Then we're heading to the lab bench to look at both classic and, the cutting-edge genomic ID methods. From there, we'll get into the clinical diseases it causes, its really tough resistance profile, how we can treat it effectively, and finally, the crucial strategies for prevention. It's really a journey from the plate to the patient. So the big question is, how does a common skin organism make that leap to a life-threatening invader? Well, it really all comes down to a specific set of risk factors that create the absolute perfect opportunity for it to strike. What's so fascinating here is how all these factors just work together. I mean, think about it. You've got a severely immunocompromised host, like a neutropenic oncology patient. They're stuck in the hospital for a long time, getting hit with broad-spectrum antibiotics that just wipe out all the competing good bacteria. And then, bam, you introduce an invasion factor, a central line, which is basically a superhighway across the skin barrier. All the while, this organism is just happily hanging out on the patient's skin and the surfaces nearby. It's this exact combination, this perfect storm, that turns a simple commensal into a killer. All right, let's switch gears and head to the lab. Identifying Corynebacterium jekeium really calls on our classic micro skills, but it's also being completely revolutionized by genomics. And that's revealing some fascinating and clinically critical complexities. Of course, it all starts with the gram stain. You see these gram-positive pleomorphic rods. They're not all the same shape. You get some coccobacilli, some club shapes, and those classic coroniform arrangements. You know the ones, the V-forms and palisades that look just like Chinese letters. For any of us at the bench, seeing this from a blood culture is that first huge clue that you might be dealing with a Corynebacterium. Now this is its most important phenotypic trait. It's lipophilic. On your standard blood agar plate, you get these tiny pinpoint grayish colonies that you could almost miss. But then you subculture it to a plate with a lipid source, like 1% tween 80, and boom, the colonies take off. And this isn't just a neat party trick. It's a powerful phenotypic alert. When you see this enhanced growth, it's strong presumptive evidence, and it lets you give the clinical team a critical heads up that they're likely dealing with a multi-drug resistant organism, pointing them towards vancomycin nice and early. Okay, and here's where genomics has just completely turned our understanding on its head. It turns out that what we've been calling Corynebacterium jekeium is actually a complex of at least 4 different genospecies. And the real kicker? The most common species actually causing human infections, Corynebacterium maclintokiae, is genetically different from the old reference strains that a lot of our historical data is based on. Wild, right? This creates a real-world headache for our lab workhorse, MALDI-TOF. I mean, it's fast, we love it, but its databases just can't reliably tell these species apart. So, for years, we've probably been misidentifying Corynebacterium maclintokiae infections as Corynebacterium jekeium. This really highlights why, for those critical isolates from blood from a prosthetic joint, we really need to be moving towards sequencing-based methods like WGS to get a definitive ID. Okay, so we've identified it in the lab. What does it actually do to the patient? Well, the clinical picture is pretty much defined by severe deep-seated infections. The classic presentation, the one we see most often, is bacteremia and sepsis and a patient with a central line. But its amazing ability to form biofilms makes it a major threat to any kind of indwelling medical device. It has this frightening tendency to go for prosthetic heart valves, causing endocarditis with a mortality rate of around 33%. It also loves to infect prosthetic joints, shunts, and pacemakers, which means source control, getting that device out, is just as important as the antibiotic therapy. And let's just pause on this number for a second. A mortality rate of up to 34% for sepsis. This is the statistic that every single one of us, microbiologists and clinicians alike, should have burned into our brains. It just powerfully demolishes any idea that this organism is just a contaminant and really underscores why we need rapid identification and super aggressive management.
Let's dive into one of its defining features, its formidable intrinsic antimicrobial resistance. This is what makes treatment such a massive challenge, and why susceptibility testing is absolutely non-negotiable for any significant isolate.
So this organism basically comes preloaded with resistance genes. It's intrinsically resistant to almost all beta-lactams and aminoglycosides. On top of that, resistance to fluoroquinolones and macrolides is extremely common. So what's our ace in the hole? The glycopeptides. It is almost universally susceptible to vancomycin, and that is precisely why this drug is the cornerstone of therapy. And for all of you performing AST in the lab, these are the current EU-CAST breakpoints that are so critical for guiding therapy. You can see the breakpoints for drugs like benzylpenicillin and ciprofloxacin are incredibly low, which just reflects the fact that you almost never see a wild-type susceptible isolate. But the most important number on this whole chart is for vancomycin. The susceptible breakpoint is less than or equal to 2 milligrams per liter. Anything above that is considered resistant. That tight margin really drives home why accurate testing is so essential. So, now we're armed with our ID and our susceptibility data. How do we translate all of this into effective treatment at the bedside? Well, the approach is pretty much dictated by that predictable resistance profile we just talked about. Let's be perfectly clear about this. The international standard of care is vancomycin. No question. If you have a patient with a severe infection and Corynebacterium jekeium is even suspected, let alone confirmed, vancomycin is the drug you start. And honestly, it's often the drug you're going to finish with too. Now, what's really useful is looking at structured guidelines, like the Dutch SWA guideline for prosthetic joint infections, because they provide such a clear pathway. You see, they start empirically with IV vancomycin, which makes sense, but if the susceptibilities allow for it, they practice excellent stewardship by de-escalating to a targeted IV therapy like benzylpenicillin. Then, they even outline several oral switch options like amoxicillin or levofloxacin, which is fantastic for completing the long treatment courses needed to get rid of these stubborn biofilm infections. For a pediatric patients, things are a little bit murkier. There aren't any specific guidelines, so treatment is pretty much extrapolated from adult data, of course with very careful dosage adjustments. There are some case reports out there, like one showing successful use of tigesicline as a salvage therapy, but this really just highlights a knowledge gap and the absolute need for an expert pediatric infectious disease consult. This brings us to the final, and I would argue, maybe the most important piece of the entire puzzle, prevention. I mean, given how ridiculously difficult this organism is to treat, preventing transmission in the first place is absolutely paramount. The strategies themselves aren't exactly revolutionary, but they require relentless consistency. It all boils down to the core infection prevention principles you'd use for any multi-drug resistant organism. It starts with meticulous hand hygiene. It requires contact precautions for any known cases, using single rooms when you can, and enhanced environmental cleaning. And critically, it demands vigilant, obsessive management of invasive devices and a really strong antimicrobial stewardship program to reduce the selective pressure that allows this tough bug to thrive. So, as we wrap things up, I want to leave you with this question to chew on. We are really on the cusp of a genomic revolution in the clinical lab. How will our growing ability to rapidly and precisely identify organisms like Corynebacterium maclintockii within this whole complex actually change our day-to-day work, our epidemiology, and ultimately our patient management? It's something to think about. And that's our explainer on Corynebacterium jekeium. We really hope this was a useful guide for you. We always welcome your feedback, so please like, subscribe, and definitely share your own experiences or any questions you have down in the comments below. Let's keep this conversation going. Thanks for tuning in.